I now want to welcome Yvette Gomez and Dr. Charlotte Owens to the main stage. They will be addressing a fireside chat on reproductive health in America. Yvette Gomez is a women's health policy analyst at the medical news outlet KFF. Her work is focused on health coverage and access for services for women, including Medicaid coverage of family planning and pregnancy-related services, Title X. She'll tell us more about Title 10 in a bit, and Medicaid postpartum extensions. If you've ever looked at the KFF postpartum Medicaid extension tracker, you'll know that Yvette is actually behind developing this important resource. Thank you, Yvette, for that. And joining Yvette is also Dr. Charlotte Owens, an OBGYN and the Senior Vice President and Head of Global Medical Affairs and Outcomes Research at Organon. To kick us off for this session, we will start with a presentation from Yvette, who will provide an overview of family planning in the United States. Yvette and Dr. Owens, thank you and welcome to the main stage.
Thank you, Joy. Good morning, everyone. Like I said, my name is Yvette Gomez, and I'm a policy analyst for the Women's Health Policy team at KFF. And this morning, I'm coming to you from very gloomy San Francisco. Oh, great. Yeah, so today I will be giving a brief overview of contraception in the US. And really the title of this should be a brief overview. Next slide, please. Great, thank you. And to just set the stage for us a little bit, I just want to start with this slide that shows that the majority of sexually active reproductive age females in the United States are using contraception, and reproductive age we define as 18 to 49 for this particular data set. And among those that are using contraception, while the majority are using it to prevent pregnancy, there is a group that is using it for some other reasons. And, 1 in 7, 15% actually said that the only reason they're using it is to prevent pregnancy, is for a reason other than to prevent pregnancy. And that could include managing a health condition or preventing an STI. And data for this slide actually comes from our KFF 2022 Women's Health Survey. Next slide. And in the US, we have an infrastructure set up to finance contraception. Something that I did not include in this slide is that most people of reproductive age, most women of reproductive age, actually have health insurance coverage, either through an employer or Medicaid or some other source, but 10% do remain uninsured. The ACA, the Affordable Care Act, requires that most private plans cover contraceptive services and supplies without any cost sharing. And you can see on this line graph to the right, it shows the share of privately insured oral contraceptive users who had out-of-pocket spending in a given year. And you can see there's this huge drop-off starting in 2012 after the ACA contraceptive mandate went into effect. And so it goes from around like 96, 98% of people having out-of-pocket costs to around 10%. And I'll note that of those 10% that still have out-of-pocket costs, it's because they're the majority of them are using brand name contraceptives that do not have generics. And then we have Medicaid, and Medicaid is the largest public payer for family planning services in the US. Family planning services are a mandatory benefit that all states have to cover without any cost sharing. And then we have Title 10, and Title 10 is a federal grant program that provides services to, or provides funding to around 4,000 clinics in the US and has historically served around 4 million underserved, lower income, and uninsured individuals. Next slide, please. And over the past 20 years, women's contraceptive choices and options have changed. Next slide. And I really here want to highlight the pill and the IUD. In the last 20 years, there's been a drop in the share of those who are using the pill, but then there's been this huge increase in those who are using an IUD. Next slide. And the types of contraceptions that female users use over the types of contraceptives that females use over the change over the course of their reproductive years. As you can see, oral contraceptives and condoms are very popular among younger females, those under 25, and then LARCs are more popular among those in the 25 to 35 age range. And then about a third of those over the age of 36 report that they are using, it's either their sterilization or their partner sterilization. Next slide, please. And so despite all these methods, we find that nearly 1 in 4 women say that they are not using their preferred method of contraception. And we found actually that Hispanic women are more likely to say they're not using their preferred method, 30% compared to 23% of white women. And when we asked women why they were not using their preferred method, concern about side effects was the top concern. But also 12% reported that they actually could not afford their preferred method, or their method was not available, or their partner didn't want them to use their preferred method. And then 9% said that their provider actually recommended a different method for them. Next slide. And so, cost is still a barrier for many people. Among uninsured women, 1 in 5 report that they had to stop using a birth control method in the past 12 months because they could not afford it. Larger shares of Black and Hispanic women compared to white women say the same, and then larger shares of those who are lower income compared to those who have higher incomes. Next slide. But now there are more pathways than ever for people to get contraception outside of a traditional clinical setting. Pharmacists are able to prescribe in over half of states. There's been an increase in the use of telecontraception apps and platforms, which are apps where people can get a prescription for birth control from a provider, and then birth control is delivered to their home. And then there's OTC, O-pill, which I made these slides last week, but actually O-pill is now available for people to order as of yesterday. So that's exciting. It's our first over-the-counter oral contraceptive pill. But there are still significant issues for us to work out. There's burden on pharmacists. There's the limited participation from insurance plans and Medicaid, limited contraceptive counseling, limited referral to IUDs and implants. And then there's the cost of O-pill, which has been set at $20 a month, and then $50 for a 3-month supply. That may be a barrier for some people. Next slide. And then there's also something for us to consider is the ongoing confusion around emergency contraceptive pills. This is data from our KFF health tracking poll from last year, and it shows responses for women ages 18 to 49. And about 26% incorrectly said that emergency contraceptive pills were the same as the abortion pill, the mifepristone pill. And then 9% were unclear about the availability over the counter of emergency contraception. Next slide. And then there's the role of social media and its role as a source of misinformation and disinformation, particularly for young people. I think a lot of young people get a lot of their information and their news from social media, and I think we all know that there is a lot of disinformation out there that is being consumed. Next slide. It's my last slide. So contraception, what's on the horizon? We will be paying attention to the courts. There's a preventative service. The preventative services requirement is currently being challenged. And then there's also debate over parental consent and contraception for minors. We'll be on the lookout for new guidelines for insurance coverage of this new over-the-counter contraceptive pill. We will be thinking of how we address misinformation and disinformation. And then, like a lot of you, we'll be paying attention to the 2024 election and its implications on women's access to sexual and reproductive health services. Next slide. So thank you. This is my email. Feel free to email me if you have any questions, or contact KFF if you have any questions for us. We're happy to help where we can. And now I invite Dr. Owens to join me. Thank you.
Thanks so much, Yvette, for sharing this information. It's really so important for us to continue to ensure that solutions have data-driven basis. While I'm not necessarily surprised by the trends like many of us here, I'm concerned by them. I wonder if you could start by discussing some of the challenges in collecting data in the first place. What were some of the hurdles?
Yeah, it's so funny that you asked that, because we are actually currently writing or finalizing our survey tool for the 2024 Women's Health Survey, which will be out in the field in a couple of months, and we will hopefully have new briefs out covering a wide range of topics, including some maternal mental health later in the fall. So a lot of the issues that are coming to my mind right now are around like putting together the survey. One of the things we have to balance is writing questions that our survey participants actually understand. I think a lot of times we want to ask these really deep questions, and we have to take a couple steps back and be like, okay, but is someone understanding the question the way I want them to understand the question? So that's something we have to keep in mind. We also have to keep in mind that we can't have a survey that's really long, despite, we want to cover a whole range of topics. But every time we have to cut so many questions, and it breaks your heart. But again, we can't have a survey, or at least I'm told we can't have a survey that's 30 minutes long. We have to respect our participants' time, and we also don't want people to drop off like halfway through. We want people to complete the whole survey.
Yeah.
So I think that it's a balance of these different of having questions that are easy to understand, but that are not too long, or a survey that's not too long. But also we have to think about, we ask a lot of questions that can be very sensitive. We cover topics like abortion, mental health, domestic violence, and it's like, again, it's like this balance of like having a survey that people will respond to without dropping off. So that's really important to us. Something we think about a lot is making sure that women of color, Black and Hispanic women, are included in our surveys. They've historically been left out of research. We're thinking about women who live in rural areas, making sure they're also in our surveys, and also thinking about people who are non-binary and transgender, and making sure that their experiences accessing sexual and reproductive health services are captured in our surveys. And then this isn't really our data we collect, but we work a lot with claims data, or my colleagues at KFF work with a lot of claims data. And a lot of that data is really messy, but it also doesn't have great race ethnicity data. So, when we're trying to analyze utilization and costs, like what people are spending, it can be, we're not always able to capture like the racial and ethnic disparities in those particular issues.
Yeah, everything you said makes sense, and it's very tempting to want to do more, but we realize that it has to be relevant and interpreted by our subjects appropriately. So based on the totality of your research, where do you think federal and local policy is heading?
That's a great question, and I wish I had a crystal ball for all of us, could save us a lot of stress for the next couple of months. I mentioned O-pill, the newly available over-the-counter pill. I think we're going to be on the lookout for any federal guidelines around insurance coverage for O-pill. So the ACA contraceptive requirement actually has language that it only applies to birth control as prescribed. So it technically does not apply to over-the-counter methods. Over-the-counter methods like the emergency contraceptive pill Plan B and its generics can be covered by insurance, but only if your physician has prescribed it.
Okay.
And that kind of defeats the purpose of an over-the-counter method. So I think we're going to be on the lookout. Also, the price of O-pill has been set at $20 a month for a month supply, $50 for a 3-month supply. We, in our women's health survey from 2022, actually had asked questions about O-pill and like how much people would be willing to pay. And only, I want to say 16% said they would be willing to pay $20 or more. So I think, there are questions about whether the price point is could be a barrier for people. So I think, so we will be paying attention to that. Along those lines, also, I suppose states could also pass laws that require coverage of over-the-counter contraceptive pills. There are currently states that have passed such laws. So in some states, you can get over-the-counter methods covered by your insurance. Unfortunately, they only apply to state managed plans. Which I won't get into because it's very complicated, but most people do not have state managed plans. So, it would be a great step, but it wouldn't apply to enough people. And then there's also the election. The election will have deep implications for people's access to health services. I mentioned Title X during my presentation. And Title X is actually a program that was heavily impacted by the 2016 election. The Trump administration passed regulations that led to about a third of the network leaving the Title X program. 6 states were left without a network. And so the Biden administration reversed many of those rules, and the network has kind of built itself back up. But if there's a change in administration, there's a potential for the program being affected once again. So I know you work at Organon, and I think we are all really curious about the role that industry plays, and wondering if you could tell us more about what a company like Organon is doing to increase access to reproductive health care.
Yeah, thanks for that question. As a global healthcare company, we're focused on improving health of women throughout their lives. Organon focuses on issues that uniquely impact women like pregnancy, menopause, endometriosis, PCOS, or impacts them differently, such as migraines. Reproductive health and contraception are a big part of meeting those unmet needs. As you know, about half of pregnancies in the US are unplanned. At Organon, we're focused on expanding access, treatment options, and innovation throughout our portfolio of medicines and devices. We also have a program called Her Plan is Her Power. It's our commitment to reducing 120 million unplanned pregnancies by 2030. To name just a few elements of this initiative, we're donating products, creating reproductive health ambassadors at historical Black colleges and universities, and funded many grants at clinics that are serving vulnerable populations across the US through a partnership with the nonprofit Direct Relief. I just returned from a listening tour for Her Plan is Her Power to 3 US clinics to learn about community-driven public health interventions that expand contraception access, education, and affordability, some of the things that you spoke about. We met with healthcare and community leaders, as well as partners in communities in Texas, Mississippi, and Ohio, because we know that these are a lot of the areas where so many contraceptive deserts exist.
Yeah, could you tell us more about what you learned in the listening sessions at the contraceptive deserts and really what people there need from us?
Yes, contraceptive deserts have similar characteristics, even though they're in different geographic areas, but they are often unique. I visited one community in a large urban county and another in a very rural community with fewer than 1,200 people. One major theme that cut across all the communities was that interventions need to address social drivers of health that affect people before they even get to the clinic waiting room. These are things like race, poverty, sexism, transportation, housing, and more. Related to these social drivers, Another standout theme was how important wraparound care is for patients. You know, this concept that you have to move beyond that one visit, that one encounter. One of the organizations had a thought, and this is so important, to actually bring care closer to the community by establishing a mobile clinic. Another has implemented what we term intracontraception care as a part of newborn and well child visits. New moms can get care for themselves to ensure that they were spacing or avoiding pregnancy as desired while getting care for their children's whose health they tend to prioritize above their own. We must focus not only on the physical health outcomes, but the mental, emotional, and financial outcomes too, because they're all related. And we know most of what makes us healthy is outside of the healthcare system. You know, so one issue that I think we cannot afford to forget in this discussion, Yvette, is that especially when we think about reproductive health and contraception access, women are only half of the story. We can't ignore the role that men play. Yvette, what do you think we should think about? How do we should think about, rather, the role of men and men's contraception from a data perspective?
That's a great question. Right now, there are only 2 contraceptive methods that have been FDA approved specifically for men. There are condoms and there are vasectomies, and that's it. I know, we always hear about the methods that are in the works. I know there is a method called Plan A that I believe is currently going through clinical trials. That would potentially be a third method that is available for men. But something that I don't think many or people don't realize is that the ACA contraceptive mandate that requires no cost coverage of contraception actually only applies to female contraception. It does not apply to vasectomies or condoms. So, people who have vasectomies face out-of-pocket costs. And condoms are an OTC product. There are some Medicaid programs that do cover condoms, but again, they do require a prescription and sometimes are limited in number. So, and again, a prescription kind of defeats the purpose of an OTC product. And so, I think questions for us to consider would be around coverage of these methods. There are states that now require insurance plans to cover vasectomies at no cost. And I believe California actually started this year, January 2024, is now requiring no cost coverage, which is great. But like I mentioned earlier, the state laws only apply to certain plans. But one thing I'll note is I showed a slide during my presentation about how people were not using their preferred method. And we actually did a follow-up and we asked women, like, what would be your preferred method? And one of the top methods that came up was actually their partner's sterilization was one of the top methods that they would have preferred. So I think that that's another thing for us to consider as well. But yeah, this might be an area where we could use some innovation with male contraceptives.
Absolutely agree. Absolutely agree.
On that note, I think that's a great note to end on. I'd really like to thank both of you on behalf of all of our attendees. I know I'm not alone in saying that I learned a lot about access. I also just wanted to quickly acknowledge that Organon convenes national nonprofits, including the Policy Center, to discuss contraception access, setting our own agendas for solutions and promoting policy change. So I just want to thank you, Organon, and thank you to both of our speakers. We look forward to looking at the latest KFF Women's Health Access Survey, and we challenge those of you who are in positions to change outcomes for women around access, including insurers and payers and policymakers who are listening today. Please stay tuned and stay connected to that important report. Thank you to both of you again.